Question number one, the guy there, sat there. So let me stay here. Okay, let's start.
Saan ang gadali? On stroke, the ischemic part of stroke. We had a lecture on the syndromes. Okay. So this is the main reference. Again, is Adams and Victor's Principle of Neurology, pages 772 to 878. Okay, so how do we approach? This is the practical approach to patients with stroke. Because this is a very common entity in the clinics, even if you're not a neurologist, at any one, most likely you will encounter stroke in the clinics or in the hospital. Huh? So, somebody presents with an acute neurologic deficit. We want to know whether this patient has a stroke or doesn't have a stroke. And we have to decide very fast because management is time dependent. Somebody has a stroke. So that's the first how we will try to recognize a case, whether it's a stroke or not a stroke. Because we know there are differential diagnoses or stroke mimics, like migraine, syncope, seizure. Then we study the pathophysiology. After knowing that this patient has a stroke, what is the mechanism? Why is it important to know the mechanism of the stroke? It helps us in our next task, which is to prevent recurrent stroke. So you have to know the mechanism so you know how to intervene depending on the mechanism of the stroke. Whether it's embolic, artery to artery embolism, or heart to the artery embolism, whether it's atherothrombotic stroke, lacunar, or a venous occlusion, or a rupture causing a hemorrhage. Okay. Then we will be able to know how to treat. The management of stroke depends on the type of stroke, whether it's a hemorrhagic stroke or an ischemic stroke. There are drugs that are contraindicated. You give it for an ischemic stroke, but it's contraindicated in a hemorrhagic type of stroke. So, pathophysiology, types of stroke, then we know how to manage stroke. And the last would be how to prevent stroke. So we have to have knowledge of basic pathology and pathophysiology. Case number one, 65-year-old auntie who is hypertensive, diabetic, and presents with sudden onset of chest heaviness, cold sweats. Is this a stroke or not a stroke? Stroke. Anyone? Not a stroke. I do not know. No, it's dangerous to say we do not know. Patient will die in the emergency room. Case number 2, 65-year-old uncle, hypertensive, smoker, sudden onset of dysarthria, left limb weakness. Stroke? Not a stroke. Okay, so what's the difference? Stroke here. Stroke is no longer called an accident or cerebrovascular accident, not anymore. We don't want to use the term accident because when you say accident, it's something that we cannot prevent. Mahitabo lang without risk factors, so something that we cannot prevent. The term is cerebrovascular disease, something that has risk factors and can be prevented. Huh? And it involves vessels. And vessels can be what? Arteries. Can it also involve veins? If you review the anatomy of the nervous system, you have arteries and you have veins. Most of strokes happens or involves the arteries, but it can also be a venous stroke. Yeah? So vessels, and what happens to the vessels? Either the vessels get occluded or the vessels ruptures. So when it's occlusion, the pathophysiology would be ischemia, loss of blood supply, oxygen, we have ischemia. And the type of necrosis is in the brain. What happens? Huh? What type of necrosis? Infarction. What type of necrosis? Yeah. Pathology. Liquefactive infarction. And do you understand why liquefactive infarction? Malata ang brain. Mahipong liquid. It liquefies. And so it ends up with a hole. A hole there. Liquefactive type of necrosis. Okay. Or the vessel gets ruptured. So you have extravasation of the blood. So you form a hematoma there. Just like when you get a bruise. It depends. If it ruptures into the parenchyma, you have a hematoma. Or if it ruptures into the subarachnoid space, you will not see a hematoma, but you will see blood in the subarachnoid space. Isn't that easy to remember? And because rupture or occlusion happens suddenly, manifestations will be sudden. So the clue to a diagnosis of stroke is sudden onset of a neurologic deficit. Depending which part of the brain is affected, if it involves the frontal lobe, what will be the manifestation?
Frontal lobe, usually cognition or
Frontal lobe.
ay,
Frontal lobe.
visual
Cognitive.
defects.
Visual field defects. Now, again, we have to review our anatomy. Depends on the function of the lobe. Frontal is motor, maybe prefrontal, behavioral. Okay. Frontal is motor. Parietal, what manifestations would you expect? Sensory. Thalamus. Now you have to remember the function of your brains, otherwise you will not understand stroke. Thalamus, expected manifestation. Wow, that was only 2 years ago. 2 years ago, anatomy. Nabalik to sa grade, first year. Cerebellum, balance. Okay, so we will have to review that. Sudden onset. Brainstem. When they develop coma, which part of the brain is affected? Kalit, loss of consciousness. Now we have a lot of things to review. Okay, 65-year-old female, hypertensive, diabetic, sudden onset of left hemiparesis and dysarthria. You have a stroke? There's a neurologic deficit, blood pressure 180 over 90, irregular heart rate. Neuro exam, the left upper extremity is 1/5, meaning it's weak, and the left lower limb is 4/5, less weak than your upper is weaker than the lower. 48-year-old male, hypertensive smoker, sudden onset of right hemiplegia and dysarthria. Do we have a stroke? Now you should be able to answer already with a big yes. Yes. 5/10 headache. BP of 180/90. The right neuro exam revealed right limbs 0/5. Upper and lower right upper limb. Right upper and lower limbs are 0/5, equally paralyzed. We have a stroke in both cases. So after deciding that we have a stroke, the next question is what type of stroke? Because we said management will differ depending on the type of stroke. Can you predict? The blue case, is it rupture or is it occlusion? Red. The red must be bleed kasi red man, blood. Can you predict? How did you predict that infarct, occlusion ang isa, rupture ang isa? Headache, rupture, and that will tell you you are more. Okay. But right now I will tell you, you cannot predict 100%. Even the most seasoned neurologists will not be able to tell just based on syndrome, clinical syndrome manifestation, whether it's an infarct, occlusion, or a bleed rupture. Nah? Okay, let's see. So cerebrovascular disease, these are just a repetition. It can involve vessels, and it can also be a pathology of the blood. What is Virtue's triad? Virtue's triad. Pathology, virtues. They form class because of three triad components. What are their predisposition or the situation where you develop clots? Virtues triad. One is endothelial damage. The other is stasis. When there's the flow is stagnant, that stroke, the blood is stroke to develop clot. And the other one is hypercoagulable, meaning components in the blood, which are. What makes it hypercoagulable? You say coagulability, what is involved? Clotting, platelets, static plaque. You know, primary hemostatic plaque, secondary hemostatic plaque. So hypercoagulability involves dysfunction of your platelets, clotting factors. And after, whether you have a rupture or an occlusion, there will be impairment of blood flow. With the impaired blood flow, you will have less oxygen, less food substrate for the neurons, so the neurons will undergo death, and that will be the sequelae of stroke. Depending on which neurons are paralyzed. If motor neurons are damaged, you will end up with paralysis, hemiplegia, quadriplegia. Okay. When you're unable to perform a function, you become disabled after a stroke. If it involves cognitive areas involving cognitive function, okay, you can end up demented. And if it involves vital structures like your brainstem, you end up dead with a stroke. So which do you want? Getting a stroke. Paralyzed, disabled, demented, or dead? Dead na lang. Let's look at this. An old study telling us what happens when you develop a stroke. Of those 2 million, almost 3 million survivors in 1991, they followed up the patient. Immediately, there will be 31% or about 1/3 of patients will require assistance. When you're a survivor, you survive the stroke, 20% will need help walking. 16% institutionalized dito siguro sa ilang mga home care facilities or in centers for the aged. Okay. And then, vocationally impaired. Now, if you're a medical student or a doctor, you're not able to work as a doctor. You're getting a stroke. You're not able to work with your profession. and about 1/3 will be unemployed. See the burden, you know the burden of stroke. That's why it's a business of everybody's business, especially here in our country where we are a poor country. Imagine you have more strokes. We have stroke patients at a young age, they become occasionally impaired. Pobre na ganun sa flood projects, mas mapobre pa tayo. Okay, burden of stroke. Second most common cause of death in the world and in the Philippines. That's what you wish. Patay na lang diretso. What if you're a survivor? First cause of long-term disability. Na you're a survivor, pero you're disabled, you're unable to work. You're a burden to the family in terms financially and support in terms of taking care of you. So we do not want that stroke. Before it used to be, when was this, in 2010? In 2010, we were saying it's 1 in 6. Now we can count 1, 2, 3, 4. You may have a stroke in your lifetime. 1, 2, 3, 4. You may have a stroke in your lifetime. And that's the reality. It's now 1 in 4 people in this room will have a stroke in their lifetime. Maybe not yet now. You're young. You may not have yet the classic established risk factors, which can be non-modifiable. Number 1 is age, no? And then those that are modifiable, like smoking. Smokers here? Oh, drinkers, alcohol, oral contraceptives. Huh? Incidence of and socioeconomic impact of stroke. Worldwide, second leading cause of death. Every 2 seconds, look at that, someone will have a stroke in the world. Every 2 seconds. And at 1 stroke, 1/3 can recover, 1/3 are left with residual disability. Maybe the other 1/3 dies. So 1/3 back to normal, almost back to normal, 1/3 with disability, 1/3 death. See the burden of stroke. The red ones there, including us, we have a high incidence of stroke. Second, this 12 million, and then in terms of dollars, it says 890 billion in 2017. That's how the world spends on stroke. In 2050, the estimated cost for stroke will be $1.6 trillion. Okay. Now we don't have that money anymore because we wasted it in our blood projects. 1 in 4, 53% of strokes occur in people under 70. And then 89% of stroke burden are in LMICs, low middle income country like ours. The burden is in us, not in the US. They have good health system. It's in us. Sa mga pobre na country. Na pobre na, mas mapobre pa with the stroke. Okay. Important to note that there are 10 modifiable risk factors responsible for over 80% of stroke. So if you want to address the problem, the burden of stroke, your strategy would be preventive. Because 80% of strokes have modifiable risk factors which can be prevented. 57% high systolic blood pressure, hypertension, 17% outdoor air pollution. Maybe this is where we don't have much efforts being done on air pollution. Huh? We're polluters in terms of how we use our fuels. 14% is, can't read it anymore. Cigarette smoking. 13% would be can't read it. Smoking. Then there's another pollution, indoor, and then what's that? Kidney disease, alcohol. So we'll discuss those risk factors. So meaning risk factors that we can do something about. No? Okay. So the two types of stroke, we've seen this. Clinically, we cannot distinguish, so we need picture of the brain. And the fastest way to get a picture of the brain, and the most widely available, is cranial CT scan. The MRI will take some time. CT scan, less than a minute you get an image ready. And if it's just to distinguish which type of stroke, whether it's an infarct or a bleed, CT scan will do. Okay, there you see the wedge-shaped black configuration of an infarct, and here you see the white hematoma. Why is it wedge-shaped? Why is an infarct wedge-shaped? So the side, the shape of the lesion is important to tell whether it's an infarct or it may be a tumor. So infarcts will have that wedge shape, triangular. Why? What is in the anatomy that makes it wedge shape, triangular? Because of the branching. So from the main stem, if you have a occlusion in the main stem, the branches goes in a wedge or triangular configuration. So the type of stroke, if you make a wild guess between case A, blue one, and the case red, your guess would be ischemia, kasi by incidence, you have more ischemia, that's about 85% ischemic or occlusion compared to a hemorrhage. Yeah? So somebody comes in with a hemiplegia, an acute onset of hemiplegia, you think it's an infarct by incidence alone. Okay. And then there are 15% hemorrhagic stroke. It can be parenchymal or it can be subarachnoid hemorrhage. And then the types of ischemic infarct, it can be an occlusion of the vessel, atherosclerotic, atherothrombotic infarct, or if the clot comes from the heart, we call it cardioembolic stroke, or from an artery, from a proximal segment of the artery to the distal branch or the distal segment, artery to artery embolism, and then it can involve the small vessel where the pathology is not atherosclerosis but lipohydrinosis usually, or you don't know the cause, you don't know the mechanism, unknown, cryptogenic. We have those categories. And as you see, the pathology, the scan there, pathology, you see the wedge shape of an infarct here, and you see the hematoma there. For sure they died, no? Because they landed on the autopsy table. Okay, so it can kill, like this one can kill, sorry. This one, what is the mechanism that this patient died? Hematoma there, herniation, pressure on the brainstem, on the thalamus, brainstem, and so it can kill the patient by pressure on the, what is responsible for consciousness? A RAS, ascending reticular activating system that runs through your brainstem. So you can get comatose when you have a stroke pressing on the brainstem or a stroke directly hitting your brainstem. Nah? Okay. And here are gross pictures of the types of stroke. You see there, this one, a small hole, small vessel is occluded, so it causes an infarct in a small area of the brain. We call that a lacunar infarct, small hole. And here you have a wedge shape, more likely a medium-sized vessel is occluded or a main trunk occlusion is occluded. And here, what do you see? Similar to this one, similar to this one, wedge shape, but then there's blood. It's an infarct with blood. What is it? An infarct that is transformed into a hemorrhage, hemorrhagic infarct. That liquefactive initially, but is fragile, so it can bleed. When you see a hemorrhagic infarct, think of the mechanism, think of cardioembolism as a mechanism of that occlusion. So that can happen. A infarct is converts into a hemorrhage because the necrotic area is fragile. And here you have the bleed, parenchymal bleed. Here you have the subarachnoid hemorrhage. It's at the base of the skull. At the base of the brain. If you have this, if you have subarachnoid hemorrhage, what is the pathology? What has caused the hemorrhage? Trauma is the number one cause, of subarachnoid hemorrhage. You bump your head, you can have a subarachnoid hemorrhage. Whereas in an atraumatic subarachnoid hemorrhage, what is the most common cause? Aneurysm. And aneurysms are formed in the circle of Willis, which is at the circle of Willis is the base of the skull, at the base of the brain. So when it ruptures, the aneurysm formed in one of the arteries in the circle of Willis, the blood is ruptures into the subarachnoid space. So there. And here you have a hemorrhage into the substance of the brain, but superficial, not deep. And you can also have a hemorrhagic component in the subarachnoid space. What is the underlying pathology? Here, it's not at the base of the brain. You have a ruptured AV malformation. So depending on the location of the hemorrhage, you can already surmise what the underlying pathology is. Subarachnoid hemorrhage, think of aneurysm. Deep parenchymal hemorrhage, what is the most common cause? Yeah, what has caused the rupture? High blood pressure. Small fragile vessels gets ruptured because of high blood pressure, uncontrolled hypertension. And the one here, superficial, parenchymal with subarachnoid hemorrhage, by the location, AV malformation. So the type of stroke again, it's important to determine whether, because we're in ischemic stroke, whether it's a large vessel occlusion or a small vessel occlusion. That you can tell based on clinical syndrome and based on CT scan or MRI findings, whether you're dealing with small vessel occlusion or a large vessel occlusion. That's an important approach. Know which vessel, what size of vessel has occluded. Okay. There, you can have possible etiologies or pathophysiology in terms of whether it's an atherosclerotic cerebrovascular disease, whether it's small vessel penetrating artery disease, so you develop a lacume, or cardiogenic embolism. And possible causes would be atrial fibrillation, valvular disease in the heart, ventricular thrombus, and other cryptogenic causes. Okay. So how will you know whether it's a large vessel disease? Based on the syndrome, it can help you predict. So look at the difference there. You have a large vessel occlusion. If this is main trunk is occluded, you will have a wedge-shaped infarct. If the terminal artery is occluded, you only have a small hole there. Why is it important to know whether it's large vessel or small vessel? Because the lesion size will matter. Large infarct, you will be worried about complications. What can you expect as a complication? Large vessel, large infarct here. Edematous brain, liquefied brain, an addition in the volume of the brain. What will happen? In a rigid compartment, you will expect Increased volume, increased pressure. With increased pressure, you will have shift in your brain, meaning you can have herniation, and that can kill. Whereas a small hole there, it may not be symptomatic at all. It may just be that you saw an infarct, incidental. Patients may not manifest at all, especially if it hits the silent area of the brain. So you may have a headache. Whereas a large infarct, you expect all signs of increased ICP. What are those signs of increased ICP or intracranial pressure? Increased intracranial pressure. Vomiting. What else? You have headache. What else? Papilledema, maybe if it's a chronic thing, but in acute phase, you may not have papilledema. Cushing's triad. What is Cushing's triad? Cushing's triad of increased ICP, increased intracranial pressure. Anyone? You can see that at bedside. Just getting the vital signs of your patient. Cushing's triad is increased blood pressure, decreased heart rate, and a change in the respiration, whether it's tachypnea or bradypnea, or irregularity in the respiratory patterns. So Cushing's triad. You will not see that when you have just a lacunar infarct or small vessel occlusion. You don't expect increased ICP or significant edema. Are you still with me? Okay, so here, types of ischemic stroke. We have to know whether it's large artery, atherosclerosis, or it's an embolic phenomenon, or small vessel occlusion, where the most likely pathology is lipohydrosis, stroke of other determined etiology, stroke of other determined etiology. No? There are those that you cannot tell what is the mechanism. You don't have the risk factors, but the patient ends up with a stroke. Okay. You call that, before we call it idiopathic. Why is it idiopathic? Huh? Because the doctor is an idiot, doesn't know the cause, and the patient is pathetic, idiopathic. We still don't know, but after some workups, maybe we'll be able to get into the cause. So here you have to review cerebral circulation, origin, because that is where you will look for the source of the stroke. No? And if it's an embolic stroke, it can be anywhere from the pump, which is the heart, to the large vessel, and artery here, or intracranial. Can it also be from a vessel in the lower limb, an embolic stroke? Or only from the heart and the carotids or the vertebrals? Can a stroke come from the lower limbs? This is a big question. From a vein, from a vein in the lower limb, can that be a source of a stroke here? Huh? From a vein here, deep vein, clot, can it end up in the brain? How? Trace. How will it end up in the brain? How will it end up in the middle cerebral artery here? Huh? Oh, so the trace from the vein here, what vein? Femoral vein there. Yeah. salt. The lungs is a screen. Sangit ito ang clot. This is the lung. You call that pulmonary embolism. Cerebral embolism. Sorry, it's salaan ng the lungs is a filter. If it's a big clot, it stays in the lungs. You call that pulmonary embolism. The patient will die of pulmonary embolism. How does it go to the brain? Okay, trace. From inferior vena cava, then vena cava. Right atrium, then it's correct. There's a septal defect from the right atrium. If you have an atrial septal defect, what is an example of a septal defect? Patent foramen ovale between two atrium. Oh. Now how will it go to the left?
From the right atrium, kay kung naakay patent foramen ovale, there will be a right to left shunt.
Okay.
And then left atrium.
So from the right atrium to the left atrium to that patent or foramen ovale, how will it happen? Remember, the pressure in the right atrium is lower than the pressure in the left atrium. So even if you have a patent foramen ovale, it doesn't cross. Kasi because of the pressure gradient. Lower the pressure sa right atrium, higher the pressure sa left atrium. So blood flow is not from the left atrium to the right atrium. How will it go to the left atrium? Superficial. What are the situations where the pressure changes? In the left atrium and the right atrium. Ma-reverse ang pressure gradient. What is the situation? Valsalva maneuver. So you will have to think, you call that a paradoxic embolus. From a vein here, it goes to the arterial side. To that patent foramen ovale, for example, if there is pressure change. When you do a Valsalva, there is a change in pressure gradient across the two chambers. We increase ang pressure sa left atrium, sa right atrium, so makatabok ang clot to the left atrium. Na-bypass ang pulmonary. So, from the left atrium, left ventricle, aorta na. Pwede na dito padulong sa brain. Why did you forget about this? This is only second year pathophysiology. Okay. Now that's why when you think of embolism, look at the situation. Kano sa stroke? So when do you have Valsalva? Every morning you do Valsalva? Yes. So somebody who has a stroke dito sa CR, baka nag-Valsalva to siya. Okay. See how we use pathophysiology trying to figure out what's going on with our patient. Okay. So you can just imagine where the source of the stroke can come from the heart to the main pipes, carotids, vertebral, or the branches of the carotids and the vertebral, basilar, middle cerebral, anterior cerebral artery, or posterior cerebral artery. Okay. There. So if the clot can be coming from the main artery here, or it can be from the heart, or in the terminal portion there. And these are the risk factors. Why will we occlude our vessel, middle cerebral artery? So you have the environmental factors, pollution, diabetes mellitus, tobacco, smoking, genetic factor. If Italians, they have good genes. No? Bisag inom kasi sigarilyo mga Italians, there are families in Italy that they are less at risk for cardiovascular disease. But Filipinos, 40 years old pa na. We have a lot of patients in the government hospital, 40 years old, they have already a stroke. No? Is it genetic or environmental? I suspect it's environmental. Why? What do we eat during calamities? Noodles, high in sodium. Delata, hindi siguro genetic, environmental, because we are a poor country, we can only afford packed foods para sa calamities. You survive a calamity, but you end up with more calamitous event, stroke. Okay. And then LDL cholesterol. Who knows? Anyone who has determined your LDLs? Here, in this class. Anyone with an LDL of 70, below 70? You don't know. Now see, it's not genetic, it's also cultural. We're not preventive. We don't know even your cholesterol. You might not know you already have a bad cholesterol of 200 or so. Okay. Obesity, nutritional factors, inactivity. Anyone doing exercise here regularly? Once a week exercise. None? Twice, 2 days a week. 3 days. 4 days a week. 4 days a week of exercise. Weekly, 4 days a week. So isa lang, meaning only one in a class of how many? And stroke is 1 in 4. Na ang stroke na karamihan is exceptionally in one lang, hindi. Exceptional only, the incidence of stroke in this class is only, how many are in class? Huh? So 118 will be at risk for stroke. Only one will have a very least risk because of inactivity. And the exercise should be moderate intensity, meaning minimum of brisk walk about 20 minutes per day, 4 days at least a week. Now, if you don't have that, you're at risk even if you're young. Okay, hypertension. Anyone with a blood pressure of 120, 70, and below? 130/80 blood pressure. You don't know? Now, how will you know you're hypertensive if you don't know your blood pressure? What is the definition of hypertension nowadays? Who is considered hypertensive? How many? What's the number? What number? Oh, who has a blood pressure 120/80 and higher? Did you know that the blood pressure now, the level of blood pressure now has gone down? It used to be, before I remember, 160/90, then 140/90, 130/80. If your blood pressure is already 130/80, that is already stage 1 hypertension. 140/90, that is already stage 2. Beyond or above 120/70, that is already considered elevated blood pressure. But the approach may be different in terms of prevention. If it's 130/80, what is our first approach? Intervention? Change. Lifestyle change. Meaning physical activity, increase, low salt. Okay, no medication yet. But when it's 140/90, it's medication already. Or if you failed lifestyle modification when your blood pressure was 130/80, meaning it persisted, then you're supposedly to take medication. 140/90, the recommendation is already dual antihypertensive medication. Now, how can we intervene if you don't know your blood pressure? Don't think you're young, your blood pressure is not yet elevated. We have seen a lot of young patients with elevated blood pressure. Who snores here at night? Snoring. You will see one of the risk factor for stroke is obstructive sleep apnea, and we can get some clues if you have that OSA, obstructive sleep apnea. If you snore, Who sleeps during lecture? Morning lectures here. Maybe that's a sign of obstructive sleep apnea, not just gabellar. Okay. So know the risk factors there because this will cause your contribute to the occlusion. We'll give you this as to read on the different causes, sources of aortic sources of cerebral embolism. Okay. How do we play this?
In AF, the heart works less effectively as a pump, with the result that there are areas within the heart where blood flow is slow or stagnant. Where this happens, blood clots can form, and these account for the increased risk of stroke associated with AF. The problem with a blood clot in the heart is that some or all of it can break away and travel along an arterial highway directly into the brain. As the blood vessels branch and become ever finer, at some stage the clot or fragment of clot is going to be too large to progress any further and will block the vessel in which it is traveling. This means that the surrounding area of the brain can no longer receive oxygen delivered by the blood, causing the nerve cells to stop working and ultimately die. This complication is called a stroke, or more precisely, an ischemic stroke. Because clots that form in the heart may be quite big, they can block wide vessels that supply large areas of the brain. Consequently, strokes arising from AF may often be fatal, or can cause temporary or permanent disabilities, depending on how long the oxygen supply to the brain is interrupted and which part of the brain was affected.
Okay. So that was what was shown was a type of stroke we call it cardioembolic stroke. Now, so coming from the heart, your clot forms a clot. What was the substrate for the formation of the clot? Why did the patient develop a clot? Because of irregular heartbeat, irregular rhythm, and of the three components of the virtuous triad. What is the likely mechanism? Stasis, because during the time of the patient, when the heart is not pumping, it can produce stasis and predisposes blood to form clot. Okay, atrial fibrillation, irregular rhythm. How do you make a diagnosis of AF? Atrial fibrillation. You take an ECG. At bedside, can you suspect atrial fibrillation? Bedside exam? This is only last year physical diagnosis. So what is the best bedside examination finding of AF? Irregular pulse. So just by the pulse, you can suspect it's AF because it's irregular. That. There's irregular. If you take the pulse, you see it's irregular. And you can confirm the atrial fibrillation in the ECG. What is the classic finding?
No P wave.
You do not have P waves. So pag wala yung P waves and then the interval between the QRS complex is irregular, immediately your diagnosis by ECG is atrial fibrillation. People you see irregular, when you take the pulse, you take an ECG, wala yung P wave, irregular ang complexes, ang interval din, AF. So until proven otherwise, when a large vessel is occluded, think of underlying cardioembolism. Kung small vessel, what is the pathology? Not likely for cardioembolism, but what is the pathology of small vessel? Lipohyalinosis. It's not atherosclerosis. Atherosclerotic arteries involves a large vessel, medium-sized vessel. Pag small vessel, lipohyalinosis. Have you seen lipohyalinosis in the pathology? Microscope. That was only last year. Lipohyalinotic vessel. Okay. So the effects of decreasing your blood flow on vital brain function. So you lose blood flow, you don't have oxygen, you don't have blood, you don't have oxygen. And see, if the blood flow becomes low, around 50 ml per 100 grams of meat, that's what happens at the cellular level. You inhibit protein synthesis, and then when the blood flow is less than 11 or less, you have membrane failure and then neuronal death. Nah? That is time dependent. The process is time dependent. But if you have zero blood flow, immediately the neurons will die. For how many minutes lang? Na zero blood flow, neurons will die. 45 minutes pa? Oh, just a few minutes. Oh. But when the blood flow is just you still have blood flow, not really zero, you still have viable cells, neurons, salvageable pa. But it is time dependent. Beyond certain hours or minutes, even if the blood flow is just compromised, eventually the neurons will die. Okay, that's an important concept to remember. Okay. Another important thing about stroke. Normally, when you're under physiologic condition, we have this autoregulation. What does it mean? Normal cerebral autoregulation. The normal autoregulation is the blue curve. And if you change the mean arterial pressure, the blood pressure, systemic blood pressure, systolic and diastolic, or better, the mean arterial pressure measured, it has a wide range where you can maintain blood flow even if, here, the blue line, even if you decrease mean arterial pressure to 60, you still maintain constant blood flow. Or if you increase cerebral mean arterial pressure to about 150, you still maintain the same constant cerebral blood flow. That is in normal individuals. But when the patient develops a stroke, an occlusive type of stroke, this is the curve there. That range where you maintain constant cerebral blood flow is lost. So when you drop the blood pressure, like here, you drop it to just less than 80 mean arterial pressure, you will compromise cerebral blood flow. Or when the mean arterial pressure increases just to about here, 90, this is maybe 90 or 100, you will not be able to maintain the blood flow. Constant blood flow, na? What is the implication? You do not drop blood pressure fast or very low, or you don't even normalize it because you will compromise blood flow. That is what we call permissive hypertension. If somebody has an acute stroke, we allow the blood pressure to go high. And what do doctors usually do in the emergency room when they see somebody with a blood pressure of 180 over 100? They give sublingual antihypertensive, and there can be precipitous drop in the blood pressure, which will be detrimental to the ischemic brain. Less perfusion, wala autoregulation, you bring it down, you will compromise the cerebral blood flow. That's which is trying to save the salvageable ischemic neurons. Yeah? So there is such thing as permissive hypertension during an acute stroke. You don't want to touch on the elevated blood pressure. Do you know how high it is where we do not intervene?
the recommendation is even 220 over 120. If it's less than that, don't do anything. Higher than that, maybe you should bring it down by 10 to 15% only. It's not reflex, knee-jerk reflex that you bring down the blood pressure immediately when it's 200 over 100. You will compromise cerebral blood flow because of the loss in autoregulation during an acute stroke. Okay. Here, what I said about ischemia, the effects on the neurons, the dying neurons, is time dependent. The red here is the area that's already dead. Just 15 minutes when you have zero blood flow to an area of the brain, that area of the brain is dead in 15 minutes. But surrounding that area, you still have this light blue here, where the blood flow is already compromised, but those neurons are still just dying or salvageable. If you restore blood flow, you improve the blood flow in that area, they can be saved, salvaged. But if you don't do anything and the blood flow is compromised after several minutes, like here, 30 minutes, you will increase that area that is dead or the core. This blue area, you call it the penumbra. It's still salvageable. It's between dying and it's dying. It can die or it can live for as long as you restore blood flow in time. If the blood flow is not restored in time, eventually they die. Okay. And it's progressing with time there. 1 hour, the core or the dead area increases in size. You have less penumbra, now less salvageable area. Until 3 hours, that penumbra is completely converted to a core, a dead core. So this is the window of opportunity where we can save neurons. We can save neurons of a patient who has an acute ischemic infarct, ischemic stroke. 3 hours. Okay. Here, the concept of time is brain. We are billionaires, diba? In terms of number of neurons in the brain, billionaires. But when an occlusion happens in the middle cerebral artery, for example, if you don't restore the blood flow, blood supply to those dying neurons, in every minute, we lose 1.9 million neurons. 1.9 million in every minute. We don't restore blood flow to this area, the ischemic, the penumbra. Or 14 billion synapses, or 20 kilometers of myelinated fibers. That's why we say, if we want to address stroke or treat stroke, we are running after time. We want to save those salvageable neurons in